Hi students, I welcome you all to MCQ discussion with Mackler. So the topic which we are going to have as an MCQ discussion here is Polycystic Ovarian Syndrome, right? So all the questions which we are going to discuss here are both the typical and atypical questions which have been asked in the previous year examinations as well as from the topic of Polycystic Ovarian Syndrome. Everything will be discussed here as a rapid revision. Clear? Yes. So to begin with, the first question is, which of the following is the most common feature of polycystic ovarian syndrome? So the first important point while solving any MCQ is that you need to just read the question very clearly, because even a single is, or even let's say for example, even they might have put some terms like except, all of the following belong to features of polycystic ovarian syndrome except. If you are going to miss that word except, the entire question is going to become wrong, right? So each and every word of the question, be it irrespective of whatever it is a question mark or it is then, was, everything has to be read. Okay, right. So which of the following is the most common feature of polycystic ovarian syndrome? So here you have to just concentrate over, they have asked about which of the following. So among these options, which is the most common feature of polycystic ovarian syndrome? So this is the question. So what are the options which are given here? Ovarian cyst, increased insulin resistance, hyperthyroidism, and menorrhagia. So let's just quickly go through it and let's cancel what are the incorrect options and select the correct options. So the first option here is ovarian cyst. Is ovarian cyst the most common feature of polycystic ovarian syndrome? No, it is not, because it is not certain that all women with PCOS should have visible ovarian cyst, and it is also not certain that whoever female is having ovarian cyst, they should have PCOS. It is not like that. There are patients of PCOS in whom the ovary is normal. But at the same time, in patients of PCOS, there might be ovarian cyst as well. So this is not a common feature of PCOS. So this option is cancelled now. The second option, increased insulin resistance. Yes, increased insulin resistance is seen in patients of polycystic ovarian syndrome. Yes, so this option is correct. What is the third option? Hyperthyroidism. Is hyperthyroidism a feature of polycystic ovarian syndrome? No, hyperthyroidism is not a feature of polycystic ovarian syndrome. The fourth option is menorrhagia. What do you mean by menorrhagia? Excessive bleeding in terms of flow as well as in number of days. So menorrhagia is a feature of polycystic ovarian syndrome? No, it is not a feature of polycystic ovarian syndrome, because we all know that because of ovulatory dysfunction, the female will have either secondary amenorrhea or oligomenorrhea as a complaint. Whereas in obese female, since they have excess amount of adipose tissue, the androgens will get converted into estrone E1 with the help of the enzyme aromatase, right? So since they have increased adipose tissue, therefore the levels of E1 is increased in them. Because of increase in E1, these obese PCOS patients might have menorrhagia, But definitely menorrhagia is not a common feature of PCOS. So this option is also cancelled. So the answer to this question is increased insulin resistance is the most common feature of polycystic ovarian syndrome in the following options which have been given. Is that clear? Fine. Let's move to the second MCQ. The Rotterdam's criteria for diagnosing polycystic ovarian syndrome requires the presence of at least two of the following. Which of the following is not included in the Rotterdam's criteria? So what is Rotterdam's criteria? So Rotterdam's criteria is the criteria which we use for the provisional diagnosis of polycystic ovarian syndrome. Mind you, it is not the confirmatory diagnosis, it is only the provisional diagnosis of polycystic ovarian syndrome. So we all know that in Rotterdam's criteria, we have three criteria, out of which two has to be positive in order to come to a provisional diagnosis of polycystic ovarian syndrome. So let's discuss it with the option. So the first option which have been given here, let me mind you here. So the question is, which of the following is not included in the Rotterdam's criteria? See, when you're going to attempt some MCQ based examination, they won't highlight this point for you. So this will be like only this, not. So there are increased chances that you might not even see this word. So it's very important for you to just see each and every single line which have been mentioned in the question. Right? Okay. So what are the options given here? Ovulatory dysfunction, ovarian dysfunction. Is that ovarian dysfunction is a feature of Rotterdam's criteria? Yes. How? Because ovarian dysfunction will manifest as menstrual irregularities. What are the menstrual irregularities in patients of PCOS? It is secondary amenorrhea and oligomenorrhea, right? So these are the menstrual irregularities due to ovulatory dysfunction. So yes, ovarian dysfunction is an option of the Rotterdam's criteria. It fulfills the criteria. Fine. Polycystic ovaries. Yes, polycystic appearing ovaries on the ultrasound when it is more than equal to 12 follicles of size 2 to 9 millimeter and one or both the ovaries or the volume of the ovaries more than 10 cc, they are a criteria of Rotterdam's criteria. So yes, this is also the right option. Then the third option here is hyperandrogenism. Yes, hyperandrogenism is a criteria of Rotterdam's. How? Because hyperandrogenism might be manifested biochemically as hyperandrogenemia, or clinically it can manifest as hirsutism, right? Hirsutism, growth of coarse hair in male pattern in females, right? So ovarian dysfunction is a feature of Rotterdam's criteria. Polycystic appearing ovaries on ultrasound is a feature of Rotterdam's criteria. Hyperandrogenism is a feature of Rotterdam's criteria. So the last option here is endometrial hyperplasia. So the question here which has been asked is, which of the following is not included in Rotterdam's criteria? So the answer to this question over here is endometrial hyperplasia is not a feature which is included in the Rotterdam's criteria. Is that clear? Yes. Now the third question. What is the primary cause of anovulation in women with PCOS? We all know that in patients of PCOS there is anovulation. Fine, yes. But what is the cause of that anovulation? It is because of increased levels of luteinizing hormone being present in that female. We all know that for ovulation to occur, there should be LH surge before ovulation. Only if LH surge is going to happen, then only ovulation is going to happen. But in patients of PCOS, the luteinizing hormones are elevated throughout the cycle. Only because of that increased luteinizing hormone, there is stimulation of the theca cells of the ovary and there is increased androgen levels in patients of PCOS. So the answer to this question over here directly is high levels of luteinizing hormone. Are you going to mark the answer blindly? No. You should never do that, right? So let's discuss it through each and every option. Low estrogen levels. Low estrogen levels is seen in patients of PCOS, right? Yes. But then E1 estrogen is increased in patients of PCOS. E1 estrone is increased in patients of PCOS. That too in obese female, E1 is present. Apart from that, low estrogen level is present in patients of PCOS. Yes. The second option over here is high levels of luteinizing hormone. Yes, high levels of luteinizing hormone is present in patients of PCOS. Only because of that, there is stimulation of theca cells of the ovary and increased androgen being produced in the female. Low level of follicular stimulating hormone? No. Actually, follicular stimulating hormone is normal in patients of PCOS. So follicular stimulating hormone is normal in patients of PCOS, whereas LH hormone is increased in patients of PCOS. And is there high levels of prolactin in patients of PCOS? No. The prolactin level is also normal in patients of PCOS. So the option over here itself is wrong, right? In patients of PCOS, prolactin level is normal. In patients of PCOS, the follicular stimulating hormone is normal. Luteinizing hormone is increased in patients of PCOS, and when it comes to estrogen, E1 is increased, rest the other forms of estrogen, E2 is decreased. So, after ruling out these options, the primary cause of anovulation in patients of PCOS is high levels of luteinizing hormone. So, by this way, it's very easy for you to just select the correct option as well. Fine? Yes. Now, moving on to the next question. Which of the following is a common symptom of PCOS? So symptom is the thing which the patient is going to present you, whereas sign is what you are going to interpret in the patient, right? So what is the complaint with which the patient is going to come to you? Most commonly in patients of PCOS is what? So the options over here are facial hirsutism. What is facial hirsutism? That is growth of coarse terminal hairs over the face of the female in male pattern, right? Yes, hirsutism is a feature, is a complaint in patients of PCOS. So yes, this is included. Excessive bleeding, no. Not excessive bleeding is not at all a complaint in patients of PCOS, but in obese patients, due to excessive androgens, there is excessive amount of conversion of androgens into E1. So because of that E1 estrone, the patient might experience menometrorrhagia, which is irregular heavy menstrual bleeding. But then excessive bleeding is not at all a complaint of majority of patients with PCOS, so this is not the option. Infertility, yes. Why? Because the most common treatable form of infertility in patients of PCOS is anovulation, right? In patients of PCOS, there is no ovulation, right? Because of that anovulation, the patient will have complaints of infertility and present to you. So the answer over here is both A and C. So facial hirsutism is also the most common complaint in patients of PCOS, as well as infertility is also the most common complaint with which the patient will come to you in patients of PCOS. Fine? Yes. The fifth question over here is, which of the following is the first line treatment? Mind you, first line treatment for menstrual irregularities in women with PCOS. So the complaint over here is menstrual irregularity. Okay, so what is the drug of choice or first line treatment for menstrual irregularity in patients of PCOS? You know the answer, that it is oral combined pills, but then it is imperative for you to go through all the options. Okay, so let's go through the options. The first option is clomiphene citrate. Clomiphene citrate is a selective estrogen receptor modulator, and it is being used in patients of PCOS to treat infertility. That is, it is used for ovulation induction in the treatment of infertility in patients of PCOS. So clomiphene citrate is never used as a first line treatment for menstrual irregularity in patients of PCOS. So this is the wrong option. What about metformin? No, metformin is only used for insulin resistance in patients of PCOS. It is not used for menstrual irregularities. This doesn't make any sense, right? So metformin is also cancelled out. The third option is combined oral contraceptives. Oral contraceptive pills, yes, so this is the answer. The drug of choice for the treatment of menstrual irregularities in patients of PCOS is combined oral contraceptives. What about GnRH agonist? So GnRH agonist, as such, it is not used as a first line treatment for menstrual irregularities, right? Because first line treatment is that treatment which has higher efficacy when compared to the next treatment, right? So in many patients, when you start oral combined pills as a treatment for this menstrual irregularity, it will get treated with this OCPs itself. But then GnRH agonist, if given in a continuous fashion, it will act as an GnRH antagonist and it will prevent menstrual irregularities. That is, it is going to stop the periods in the patient itself. But it is not used as a first line treatment for menstrual irregularities in patients of PCOS. So the answer over here, the first line treatment for the management of menstrual irregularities in patients of PCOS is oral combined pills or combined oral contraceptives. Is that clear? Yes. What is the role of metformin in the management of polycystic ovarian syndrome? So just before I told you that the role of metformin in treatment of PCOS is, it is used in the treatment of insulin resistance. So any patients in patients of PCOS, if they have insulin resistance, then the treatment is going to be metformin. What about insulin resistance in patients of PCOS? It will manifest as acanthosis nigricans, which means appearance of dark thick skins in the nape of the necks, in the armpit, in the upper chest, everywhere it will be present. So for the treatment of insulin resistance, since the levels of insulin are increased and it is resistant for the proper uptake of the glucose, therefore you have to supplement metformin for the treatment of insulin resistance. Once you're going to produce this metformin to the patient, it is going to improve the insulin sensitivity, right? So the answer over here is to improve the insulin sensitivity. So what are the options which are provided here? to regulate the menstrual cycle? No, metformin is not used for regulatory of menstrual cycle, so this is cancelled. To reduce hirsutism? No, metformin is not used in the treatment of hirsutism. To improve the insulin sensitivity? Yes, it is used to improve the insulin sensitivity. To induce ovulation? No, metformin is not used for inducing ovulation. Right? So this makes sense itself. To improve the insulin sensitivity, metformin is used in the management of polycystic ovarian syndrome. Fine. Next question. Which of the following hormonal abnormalities is most commonly seen in patients of PCOS? So what is the hormonal abnormality which is most commonly seen in women with PCOS? So the options here are high progesterone level. Now tell me, high progesterone level is seen in patients of PCOS or not? No. Progesterone levels are decreased in patients of PCOS. Why? Since there is anovulation in patients of PCOS, once there is no ovulation happening, there is no formation of corpus luteum. If there is no corpus luteum, there is no progesterone. So therefore, there is a decreased amount of progesterone in patients of PCOS. So this option is ruled out. Low testosterone level. No, this is a blunder, because we all know that in patients of PCOS, the one hormone which is going to be increased is increased androgen or increased testosterone. So low testosterone level is an incorrect option over here. Elevated prolactin level? No, because prolactin levels are normal in patients of PCOS. So this option is also ruled out. So the answer here is high LH to FSH ratio is the most common hormonal abnormality seen in women with PCOS. How it is altered? Because we all know that the normal LH is to FSH ratio is 1:1. But in patients of PCOS, it is either 2:1 or 3:1 due to increase in luteinizing hormone levels. So high LH to FSH ratio is the most common hormonal abnormality seen in women with PCOS. Clear? Yes. The next MCQ. Which ultrasound finding is characteristic of polycystic ovarian syndrome? The answer over here are ovarian enlargement with multiple small cysts, large solitary ovarian cyst, enlarged uterus with fibroids, thickened endometrium. So, just by common sense, we can rule out many options over here. So, thickened endometrium is not seen in patients of PCOS, right? For the endometrium to be very thick, estrogen is very important to prime the endometrium. But in patients of PCOS, the estrogen level is decreased. The E1 estrogen level is increased, right? So, that is not thickened endometrium is not a ultrasound characteristic in patients of PCOS. And large uterus with fibroid is not seen in patients of PCOS, no. Large solitary ovarian cyst, no. It is not a single ovarian cyst. It is a multiple small ovarian antral follicle suppression. So this option is also ruled out. So the answer over here is ovarian enlargement with multiple small immature antral follicles or cyst. So this is the option. Fine. Right. Women with polycystic ovarian syndrome are at increased risk for developing which of the following conditions? So the options over here are endometrial carcinoma, ovarian cancer, cervical cancer, and breast cancer. So women with PCOS are at increased risk of developing which of the following conditions? So let me come back to this question after some time, right? So only after discussing few questions, it might be easy for you to just conclude. Fine. So the next question over here is which of the following medication is used to treat hirsutism in patients of PCOS? So what is hirsutism? So hirsutism is growth of coarse terminal hair in male pattern in females, right? For the treatment of hirsutism, what are the drug of choice? So the options over here are oral contraceptives, spironolactone, metformin, and clomiphene citrate. Oral contraceptives are used in management of hirsutism. Yes, it is used. Spironolactone, yes, spironolactone is also used. Why? Because it is the anti-androgenic drug which is going to decrease the amount of androgen in the female and it is going to cause improvement in the symptoms of hirsutism. Metformin has nothing to do with hirsutism, so metformin is the wrong option. And clomiphene citrate is used as an ovulation induction agent, so clomiphene citrate is also the wrong option. So the answer to this question is oral contraceptives and spironolactone. Right? So oral contraceptives and spironolactone. But if you want me to select only one options, what am I going to select? See, the question over here is which of the following medication is used to treat. So, if the question is which of the following, then definitely an option will be provided here as both A and B. Right? Because in patients of PCOS for treatment of hirsutism, first we are going to try with oral contraceptive pills for a period of about 6 months. Even after 6 months, if there is no improvement in symptoms of hirsutism, then you have to give anti-androgenic drugs such as spironolactone. Right? So the answer over here could be two things. One is oral contraceptives and the spironolactone. Initially you start with oral contraceptives. If there is no improvement, you go for spironolactone. So therefore, with respect to this question, the option could be both A and B. What is the most common complication associated with PCOS in pregnant women? So the options are gestational diabetes, preterm labor, ectopic pregnancy and preeclampsia. So we have 4 options available over here. We all know that in patients of PCOS there is insulin resistance. There is insulin resistance in patients of PCOS. Majority, like 50 to 80% of the females is going to have insulin resistance. And if she is going to get pregnant now, there are increased chances that due to this insulin resistance, because the chances of insulin resistance in pregnancy itself is increased. Adding to that, insulin resistance is also present in patients of PCOS. So due to this insulin resistance, the patient might develop gestational diabetes. Right? Yes, she can develop gestational diabetes. The second option is preterm labor. Preterm labor can happen in patients of PCOS who have conceived, but then it is not the most common complication which is associated with PCOS in pregnant women. Why preterm labor happens in patients of PCOS who are pregnant are, in patients of PCOS there is always hormonal abnormalities being present, because we can't even predict at what particular time what hormone will be increased or it will be decreased. There are multiple hormonal abnormalities or imbalances present in patients of PCOS. So because of that reason, preterm labor can happen in the patients of PCOS, right? But it is not the most common complication seen in patients of PCOS in pregnant women. So therefore, with respect to the most common complication, the answer is going to be gestational diabetes, because PCOS in itself has insulin resistance. In patients of pregnant females, insulin resistance is present generally itself. So adding to this insulin resistance, it is going to result in gestational diabetes mellitus. Is that clear? Yes. What about the next two options, ectopic pregnancy and preeclampsia? No, it is not linked anywhere to PCOS. But definitely gestational diabetes and preterm labor are linked with PCOS patient. But the most common complication is gestational diabetes. Is that clear? Yes. The next question over here is, which of the following laboratory test is most commonly used to assess the androgen levels in PCOS patient? If you want to check the androgen levels, what is the one important laboratory test you have to assess? So I need to check the serum testosterone levels, right? Androgens are nothing but testosterone. If you want to check the androgen level, you check the androgen. If you want to check the blood sugar level, you have to do the blood sugar evaluation. Similarly, if you want to do the androgenic evaluation, you have to check the serum testosterone levels. The options over here are FSH, LH, testosterone and prolactin. No. So these options are ruled out and testosterone is the answer over here. Is that clear? The next question over here is, which of the following is a characteristic feature of the ovarian morphology seen in PCOS on ultrasound? So the options here are presence of a single large cyst. No, because we all know that multiple immature cysts are present in patients of PCOS. So this is ruled out. Presence of multiple small follicles which are arranged in a string of pearls appearance. Yes, presence of multiple immature ovarian antral follicles which are arranged in a string of pearls appearance or necklace pattern appearance. So this is the right option. What about the third? Increased blood flow to the ovary? No. Thickened endometrial lining? No. So the characteristic feature of the ovarian morphology, right? They are asking about the ovary here. And they're asking about the characteristic feature of the ovary in patients of PCOS. So the answer over here is presence of multiple small ovarian follicles which are arranged in a string of pearls appearance. Clear? Yes. The next question over here, which lifestyle modification is most beneficial for women with PCOS who are overweight? So they have given the question and they have given the hint also over here. So they have told here that the patient is an overweight patient, right? What is the lifestyle modification you have to advise to a patient of overweight PCOS case? You have to ask them to do a weight loss program with regular physical activity. You do some dietary modification and along with that you do some regular physical activity and you implement a weight loss program. So the answer over here is not. Increased protein intake is not an answer. Avoid carbohydrate is not an option. High fat diet is not an option. Implementing a weight loss program with regular physical activity. So definitely lifestyle modification has to be advised to every patient with PCOS, because even a significant amount of weight loss, even let's say for example 5 to 10% of weight loss might be very beneficial to patients of PCOS in resuming their menstrual cycle as well. Clear? Yes. The next question over here, what is the effect of PCOS on fertility? The options are, it enhances the fertility. No, PCOS doesn't enhance the fertility. It usually causes anovulation which can lead to infertility. Yes, because PCOS is a condition where there is anovulation, right? There is anovulation in patients of PCOS due to increase in luteinizing hormone level throughout the cycle. So since there is anovulation, there is no release of mature ovum. So therefore, there is no chance of conception. So the patient is going to come to you with complaints of infertility. So it usually causes anovulation, which will lead to infertility. It leads to early menopause? No. It has no impact on fertility? No. The answer over here, this question, is usually causes anovulation which can lead to infertility. Right? Fine. Next question. Which of the following is a characteristic finding on ultrasound in a patient with PCOS? See, similar questions are repeated elsewhere here because these are the questions which are more commonly been expected in any examination. Multiple large cysts in both the ovaries, single large cyst in one ovary, string of pearls appearance with multiple small cysts, thickened endometrium. See, you might be seeing this thickened endometrium feature in all such questions. Why are they mentioning this thickened endometrium? See, in patients of PCOS, there is anovulation. When there is anovulation, there is unopposed estrogen action towards the endometrium. So this unopposed estrogen is going to prime the endometrium and increase the thickness of the endometrium. So therefore, thickened endometrium can be present because of the hormone estrone E1, but then thickened endometrium is not a characteristic feature in patients of PCOS. So therefore, they are mentioning this thickened endometrium as an option over every question. But you shouldn't be confused with respect to thickened endometrium. So with respect to this point, let me discuss this question also. Women with PCOS are at increased risk of developing which of the following conditions? Just now I told you that in patients with PCOS there is unopposed estrogenic action towards the endometrium, right? unopposed estrogenic action towards the endometrium, and this estrogen E1 is going to do proliferation of the uterine endometrium, and because of hyperproliferated endometrium, the endometrial thickness might be increased. But this, if in a chronic term, if the same thing is going to happen because of chronic increased endometrial thickness, this might result in endometrial carcinoma, right? So women with PCOS are at increased risk for developing endometrial carcinoma. So that is the option over here, right? Ovarian cancer, cervical cancer and breast cancer are ruled out. So the answer to this question is endometrial carcinoma because of unopposed estrogenic action towards the uterine endometrium in patients of PCOS. Fine. Because in patients of PCOS, estrone E1 is increased. Estradiol is decreased, but estrone E1 is increased in patients of PCOS. Fine. So coming back to the original question, which of the following is a characteristic finding on ultrasound in patients with PCOS? The first option here they have given multiple large cysts. No, it is not. It is definitely multiple cysts, but then it is definitely not multiple large cysts. Those are multiple small immature follicles. So this option is also ruled out. Small large cyst in one ovary? No. String of pearls appearance with multiple small cysts? Yes. So this is the answer to this question. Thick and endometrium, again it is not a characteristic feature in patients of PCOS and ultrasound. So this is also ruled out. So the answer to this question is string of pearls appearance with multiple small cysts. The primary cause of anovulation in PCOS is very clear. The options are excessive FSH secretion. No, FSH is normal in patients of PCOS, so that option is ruled out. The second is high LH to FSH ratio. Yes, LH is increased in patients of PCOS, so LH FSH ratio is increased. So high LH FSH ratio. Decreased LH secretion. No, there is no decreased LH secretion. LH levels increase throughout the cycle in patients of PCOS. Elevated progesterone levels. No, progesterone levels are decreased in patients of PCOS due to anovulation, right? So the answer to this question is high LH FSH ratio. The next question over here, in management of PCOS, which of the following medications is primarily used to induce the ovulation? So they indirectly mean treatment of infertility in patients of PCOS. So what is the treatment of infertility in patients of PCOS? So first of all, infertility in patients of PCOS is due to anovulation, and anovulation is the most easily treatable form of infertility. So you have to just treat the cause anovulation, so therefore you have to induce the ovulation in patients of PCOS. So what is the drug of choice for ovulation induction? So the drug of choice for ovulation induction in general it is clomiphene, citrate and letrozole. But in patients of PCOS, the drug of choice for ovulation induction is letrozole. It is not clomiphene citrate, it is most commonly letrozole. In general, it is clomiphene citrate followed by letrozole. But in patients of PCOS, for ovulation induction, the drug of choice is letrozole. If letrozole is not given in the options, the next thing you can select is clomiphene citrate. So the answer over here is clomiphene citrate. Metformin is used for only insulin resistance, so it induces the insulin sensitivity. Oral contraceptives, it doesn't have any effect to induce ovulation, no. Spironolactone is an anti-androgenic drug, it has nothing to do with ovulation. So clomiphene citrate is the answer for this question over here. If letrozole is given in this option, let's say for example instead of metformin, letrozole is given, so then the option will become letrozole, right? Fine. The next question, the Rotterdam's criteria for diagnosing PCOS requires the presence of at least two of the following three criteria. Which of the following is not included? Ovarian cyst, yes, we discussed. Elevated testosterone levels, irregular menstrual cycles and elevated prolactin levels. Ovarian cyst definitely included in Rotterdam's criteria because presence of ovarian follicles of size 2 to 9 millimeter more than equal to 12 number of follicles in one or both the ovaries or volume of the ovaries more than 10 cc is a criteria of PCOS. So yes, ovarian cyst is an option. Elevated testosterone levels, which means hyperandrogenism, which can be manifested biochemically as hyperandrogenemia or clinically as hirsutism. So elevated testosterone is also an option. Irregular menstrual cycle due to ovulatory dysfunction such as secondary amenorrhea and oligomenorrhea. Yes, this is also included in the Rotterdam's criteria. The one option which is not included in Rotterdam's criteria is elevated prolactin levels. In patients of PCOS, prolactin is normal and prolactin is not included in Rotterdam's criteria. Is that clear? Fine. The next question over here, a 24-year-old woman presents with irregular menses, obesity and hirsutism. On ultrasound, multiple small cysts are found in both the ovaries. Which of the following is the most likely diagnosis? So 24-year-old female, reproductive age group female, complains irregular menses, obesity, yes, hirsutism is there. Fine. So in this itself, two criteria are fulfilled, which is irregular menses due to ovulatory dysfunction is fulfilled, hirsutism due to hyperandrogenism is fulfilled. So 2 out of 3 is fulfilled. So therefore, this is a provisional diagnosis of PCOS. And apart from that, on ultrasound, multiple small cysts are found in both the ovaries. So the most likely diagnosis over here is polycystic ovarian syndrome. Fine? Yes. The next question, which of the following is a common endocrine abnormality in PCOS? So the options are elevated prolactin. No, prolactin is normal in patients of PCOS. Increased luteinizing hormone. Yes, luteinizing hormone is increased in patients of PCOS. The third option, elevated thyroid stimulating hormone. No, it is not a feature of PCOS. No. Low testosterone. No, testosterone levels are increased in patients of PCOS. So the answer over here is increased luteinizing hormone is the most common endocrinal abnormality in patients of PCOS. Fine. Next question, which of the following medication is commonly prescribed for managing hirsutism in women with PCOS? So management of hirsutism in women with PCOS. So the first is oral contraceptive pills, which has to be given for 6 months. If there is no improvement in symptoms, you have to supplement anti-androgenic drugs along with oral contraceptive pills. We have discussed this already in the theory itself, right? We discussed in the class on the polycystic ovarian syndrome as itself, but then here I would like to just reinforce that point again. You have to give oral contraceptive pills along with spironolactone in a patient who is trying to conceive, because by chance if she is going to conceive a male fetus in her uterus, these anti-androgenic drugs might take effect into the male fetus and result in feminization of the male fetus and result in ambiguous genitalia. So to prevent this major blunder adverse effect, you have to give oral contraceptive pills for birth spacing and you have to give spironolactone anti-androgenic drug in treatment of hirsutism in patients of PCOS who are trying to conceive. Right? So metformin, spironolactone, clomiphene citrate and bromocriptine. So which is the drug of choice for managing hirsutism in patients with PCOS? So it is anti-androgenic drug, that is spironolactone. The other options are wrong. Which of the following is a common long-term complication of PCOS? I told you that because of unopposed estrogenic action towards the endometrium due to anovulation, the patient are at increased risk of endometrial cancer. So the answer to this question is endometrial carcinoma. Fine? Yes. The next question, a 25-year-old woman with PCOS complains of weight gain and irregular periods. She is diagnosed with insulin resistance. Which of the following treatment is recommended to improve her insulin sensitivity? So to improve the insulin sensitivity, or in other words, the drug of choice for insulin resistance in patients of PCOS is metformin. So the answer over here is metformin. Oral contraceptives, no. Clomiphene citrate is also wrong. Clomiphene citrate is also wrong option. Spironolactone is also the wrong option over here. A patient with PCOS who is planning pregnancy is given clomiphene citrate. What is the mechanism of action of clomiphene citrate? So the mechanism of action of clomiphene citrate is ovulation induction through increase in follicular stimulating hormone. So the answer over here, this question, is increased FSH secretion, right? The next question. Which of the following is the most common endocrinal disorder in women of reproductive age group? The most common endocrinal disorder in women of reproductive age group is polycystic ovarian syndrome, right? Polycystic ovarian syndrome is the most common endocrinal disorder in women of reproductive age group. So what are the options provided? PCOS, hypothyroidism, hyperprolactinemia, primary ovarian insufficiency. Mind you, hypothyroidism is also very common in women of reproductive age group. Yes, but then it is not much common as PCOS. So polycystic ovarian syndrome is the most common endocrinal disorder in women of reproductive age group, right? But if the question is going to mention what is the most common endocrinal disorder in women of elderly age group, then the answer is going to be hypothyroidism instead of PCOS. Is that clear? But the answer over here, this question, is PCOS. The next question, a 30-year-old woman with PCOS is found to have irregular menses and infertility. Which of the following is the most appropriate first-line treatment for ovulation induction? So, the first line treatment for ovulation induction in patients of PCOS is always letrozole, followed by clomiphene citrate. So letrozole is not given in the option. So therefore, the drug of choice for treatment of ovulation induction in patients of PCOS is clomiphene citrate, right? In women with PCOS, which of the following hormonal abnormalities is most commonly observed? High LH, low FSH, high FSH and low LH, low estrogen and high progesterone, elevated prolactin and low LH. So we can just rule out with the features of PCOS itself. High LH is seen in patients of PCOS, yes, but low FSH is not seen because FSH is normal in patients of PCOS. So therefore, this option is ruled out. High FSH and low LH, no. LH is increased in patients of PCOS. FSH is normal in patients of PCOS. Low estrogen and high progesterone. Estrogen E1 is increased in patients of PCOS. Progesterone is decreased in patients of PCOS. So this is also ruled out. Elevated prolactin and low LH. Prolactin level is normal in patients of PCOS. And low LH, no, LH is actually increased in patients of PCOS. So this option is also ruled out. So over here, high LH and low FSH can be considered as an option, right? Because LH is definitely increased in patients of PCOS and FSH could be normal as well as it could be low as well. So in the four options, the best option could be high LH and low FSH. Because FSH is never increased in patients of PCOS. It is either normal or decreased. So you can take it as high LH and low FSH. Clear? Yes. The next question over here. A 28-year-old woman with PCOS is experiencing irregular periods, hirsutism and acne. What is the primary role of oral contraceptive pills in management of PCOS? So we all know that oral contraceptive pills is used as a drug of choice for menstrual irregularities and drug of choice for hirsutism. So therefore, the answer over here is to regulate the menstrual cycle and to reduce the hirsutism. Clear? It is not used to induce ovulation. It doesn't improve the insulin sensitivity. It is never used to decrease the testosterone production. So other options are ruled out. The next question, in the women with PCOS who has been trying to conceive for about 12 months without success, what is the next step in treatment after lifestyle changes and metformin? In vitro fertilization, laparoscopic ovarian drilling, clomiphene citrate for ovulation induction, gonadotropin therapy. See, option A, C and D. All the three are used for the treatment of infertility in patients of PCOS. But then, in order to select the right option, you have to just focus more upon the question. Because the question here, over here, it has been mentioned that the female is trying to conceive. So, she hasn't adopted any method or she hasn't gone for any ovulation induction treatment or she hasn't done any artificial procedures as such now. She's just trying to conceive through a natural method. So the next step in the treatment after lifestyle modification is ovulation induction. So ovulation induction is done with the help of clomiphene citrate in patients of PCOS. No, it is letrozole. But when letrozole is not provided in the option, you can select clomiphene citrate for ovulation induction. So please be very careful, right? You should never mention, since it is mentioned that after over 12 months she has been trying to conceive but without success, you shouldn't go to the anthrus in vitro fertilization. No, this is not the answer. The next option, best option would be clomiphene citrate for ovulation induction. Is that clear? Yes. So we have just come to the last question of this MCQ discussion. So which of the following feature is least likely to be associated with polycystic ovarian syndrome? So the question here, the answers are obesity. Yes, obesity can be seen in patients of PCOS, right? It is not very certain that only obese people have to have PCOS. No, because both thin as well as obese PCOS patients are there. So, but obesity can also be a feature, right? So, obesity is a feature associated with PCOS, right? Infertility, yes, due to anovulation. Infertility is also associated with PCOS. Dyslipidemia, yes, I told you that because low density lipoprotein is increased in patients of PCOS, high density lipoprotein is decreased in patients of PCOS. Therefore, dyslipidemia can also occur as a long-term complication, yes. So, this is not the option. So, which is the least likely condition to be associated with PCOS? Here is the answer over here is early menopause is the least likely condition to be associated with polycystic ovarian syndrome, right? So in the similar fashion, it's very easy for us. Once you know the concept, once you are thorough with the concept, you can just solve any MCQ just by focusing on what the question is asked and what are the options being provided in the answer. So just by solving the question itself, it will become as a habit for you, so that without even thinking, you can just go through the question and the answer options and your mind itself automatically select the right option, right? So let's meet in another interesting MCQ discussion. Until then, please keep studying. If you have any doubt, please write to us in the Mackler